Okay, let's get going. Good evening, everyone, and thank you for joining us for the next in our series of webinars from Ophthalmic Consultants of London. Thank you to everyone who has joined us for our previous ones, and a huge welcome to everyone that's joining us for the first time. As always, this webinar is recorded, as have been the previous ones, and will be available to watch on our YouTube channel, Ophthalmic Consultants of London. There is one CET point available for this webinar for optometrists, dispensing opticians, and contact lens optician, if you are watching it live with the link that you got when you registered for it. This lecture will run for 45 minutes with questions at the end. So if you do have any questions, please pop them in the Q&A box at the bottom of the screen, and we will get through as many as we can at the end of the lecture. So today's speaker is Romesh Angunawela. Rom is a director and founding partner of OCL. He is a consultant eye surgeon at Moorfields Eye Hospital, where he is also director for corneal training. He is a leading specialist in laser eye surgery, cataract and lens replacements, and corneal transplant. Ron, thanks very much. If you'd like to unmute yourself and share your screen, I'll pass it over to you.
Thanks, Privy. Let me just get the right screen up here. There we go. So thanks all for joining. So I'm just going to give you an update on keratoconus management, and I'm sure you see a lot of keratoconic patients in your practice, and we certainly do here. So just to go through, some key aspects of modern management of keratoconus, the key things really are detection, because a lot of people aren't detected early enough, treatment, which I'll talk to you about, and then visual rehabilitation. So the key parts that optometrists pay in this really are the detection part and being suspicious of your patients having keratoconus and then referring them on appropriately. And then, of course, the visual rehabilitation, because ultimately glasses and contact lenses still remain the number one way of seeing better in the majority of these people. So very briefly, to go through what keratoconus is, it's a non-inflammatory condition where there's progressive thinning and bulging of the cornea and distortion of the cornea. And as you know from these patients, in more extreme cases, you can see a sort of conical shape to the cornea. And in milder cases, you have irregular astigmatism and increasing astigmatism, which is a telltale sign. So patients with the condition are troubled by blurred vision, sensitivity to light, difficulty seeing at night, particularly in more advanced cases. And if you look at the incidence of this in the UK, it varies depending on the racial demographic of the patients. So Caucasian patients are thought to have keratoconus in 1 in 2,000 people, but that increases significantly in Asian or Afro-Caribbean populations, and more common in Arabic populations. So in Asians, it can be 1 in 400 or 1 in 500 cases where you may have some keratoconus. So, what's going on in these patients in terms of their corneas? There have been various theories proposed, but essentially there is a biomechanical weakness in the cornea. And the theory from studies that have been done looking at the architecture of these fibrils of collagen are that there's some abnormality in the keratocytes, which are the cells that exist between the collagen fibers, and they're causing some proteolysis or weakening of these fibers. And the fibers stretch from limbus to limbus, and when there's weakening of that, they stretch outwards and begin to bulge in an odd way. That's some of the theory. Now, people are trying to identify why people get it. It's complicated. There have been various genes identified. So it's polygenetic. There's no one gene that can kind of cause it. It's really a lottery as to which genetic cards you're dealt. Sorry about this. Yeah, there we go. As to which genetic cards you're dealt in terms of your expression of this. But there's low correlation between some of these genes and the actual phenotype of whether the patient gets keratoconus or not. And if you look at, patients will ask you, look, I've got keratoconus, what's my risk of transmitting this on to my offspring, it's not inherited in a Mendelian way. So on average, 8 to 10% of patients have a relative with keratoconus. So there's more to it than just these various genes that have been identified. And the other factor are called epigenetic factors. So there's this thing called the two-hit hypothesis, which you may have heard about. And that's where you have a genetic predisposition. So one of those genes that was in the previous slide, and then the epigenetic factor puts you makes you have the bulging or the ectasia of the cornea. So that's the second hit, which causes that. And that second hit could be a number of different things. So common risk is eye rubbing, contact lens wear, and contact lens wear because people are handling their eyes and corneas, and they rub their eyes due to contact lens relief when they take it off. People with Down syndrome tend to have a high risk of getting keratoconus. Allergies, eczema, asthma, all atopic conditions make you much more likely to rub your eyes. Sun exposure has been proposed as a risk, and that's because of the oxidative stress to the collagen fibers and the cornea. And in pregnancy, your tissues become a little bit more lax. So connective tissue disorders can predispose you to getting this kind of ectasia. But some of these things are difficult to control. But eye rubbing is something that you should be advising your patients about. And this is a interesting video. Some of you might have seen this online. It was done by the Rothschild Foundation in Paris, and my previous trainee was involved there in this research project. So they basically put a doctor into an MRI scanner and got them to rub their eyes, and you can really see how much deformation of the cornea occurs when you're rubbing your eyes. And it's a great video to show patients who have early keratoconus or who are at risk of developing it as to why they shouldn't be rubbing their eyes so vigorously. In general, I tell them to try and avoid rubbing over their cornea because, in reality, it's unrealistic probably to think that they'll never rub their eyes. And I ask them to rub either the corner or the outer corner where the sclera is, which is tougher. But rubbing over your cornea, if you're predisposed to ectasia, is not a good idea. And these MRI scans really show how much change occurs there. So when I gave this talk before, I asked the audience what these signs were, but I'm just going to go through them because we can't interact at this point. So Vogt striae, you'll see, which are these sort of marks on the back surface of the cornea where there are stress lines. A Fleischer ring occurs because of iron deposition where the cone is, and it can demarcate the outline of where the cone is bulging forward. Apical thinning, which I'm sure you're familiar with, you can see on a thin slit beam. Munson's sign occurs in kind of more advanced cases of keratoconus. We get the patient to look down and you can see the lid being deformed in a conical way. Of course, acute hydrops, and that occurs when there's a split in Descemet's membrane, allowing aqueous to get into the stroma, and it then acutely swells up and the patient's vision drops. So some of the clinical signs of keratoconus. But as you know, in optometry practice, it isn't easy to pick up these patients when they have mild amounts of keratoconus. It's easy to pick it up when you've got topography scanning, and you can see this sort of asymmetrical steepening that occurs in patients with keratoconus. So other signs which should make you feel suspicious if you see these patients in your clinic are a scissoring reflex on retinoscopy. Increasing astigmatism or unstable astigmatism should make you feel suspicious that there's something odd going on. If there's irregular astigmatism on the surface on a topography scan, astigmatism over 5 diopters is odd. If you have the ability to get a topography map of the surface, any abnormal, anomalous topography can be suggestive of that. And if there's an asymmetric bow tie pattern, as in this image here, you probably want to refer that patient in. Keratometry values over 49 are thought to be suspicious. Pictometry values or thickness of the cornea below 470, reduced best spectacle corrected visual acuity in your patient who previously maybe had it, and a history of eye rubbing or allergy or a family history of keratoconus. All of those things should make you feel suspicious that, or at least question, could this patient have keratoconus? Because that first stage of managing these patients is detection, and early detection means that we can do something about maintaining good vision. So I'm not going to go too much into imaging, but a lot of imaging is based on placido disc imaging and height mapping. So you'll be surprised that if you actually have a placido disc, which you occasionally find these days in clinics, you can see these distorted kind of patterns in these patients. In the clinic now, the gold standard way of really monitoring these patients is Scheinfeld-based corneal tomography, and that's the Pentacam or any other kind of device similar to that, like the Sirius or Swepsos OCT that can look at height differences in the cornea. And that's really our go-to kind of technology, and that even in mild cases makes it obvious as to whether they have keratoconus or not. And there's different grading systems based on signs and keratometry values, and it goes from grades 1 to 4 in terms of severity, and that's the Krumage classification, which is probably the simplest one out there. Again, I'm not really going to go into that because I'm really going to talk about treatment today. Are these scanners good? They're good, but they're not perfect. They're good at detecting change in mild to moderate keratoconic patients, but in severe patients where their keratometry values are very high, there can be quite a lot of variability in their scans. So trying to track progression, for instance, can be difficult in the clinic setting. It's also difficult because they often wear hard contact lenses and other types of lenses which change the shape of the cornea, and you've got to try and keep it regular as to at what point they remove the contact lens. Ideally, it should be 2 weeks before to give a accurate map of the cornea, but that's totally unrealistic in people's real life situations. So we generally try and get them to take it out the day before they come to clinic and stick to that pattern, because at least we've got some consistency. But it's not always easy in the more advanced cases to judge what's going on with just the topography maps. So other technologies that we're using now to try and detect these patients are looking at the actual biomechanics. This is the Oculus Corvis, so the same company that makes Pentacam, and I have no commercial interest in this at all, but you can deform the cornea and look at metrics of how quickly the shape recovers, and that gives you some measurements which can tell you whether the biomechanics of the cornea are normal. So, that can be useful in patients where the topography is equivocal and you want some extra data on, is the underlying cornea as strong as it should be. So Corvis or dynamic kind of hysteresis measurements are useful. Not currently commercially available is this kind of optical elastography, which is called Brilliant microscopy. That really does show some incredible promise, but there's no clinical device available. It's still in the laboratory kind of setting, but that will also change the way we see segment eye exams. So what we do use at OCL is epithelial thickness mapping in cases that aren't very obvious. The epithelium initially acts as a masking kind of layer for underlying ectasia. So in early cases, you can have a normal topography, but the overlying epithelium is thinner in the area where there might be some subclinical bulging. So being able to measure that accurately, and this is using the OptoView OCT, allows us to look at our patients who don't have obvious keratoconus and work out whether they do have some sort of subclinical form of it. That's also useful in patients who are about to have refractive surgery like LASIK, where we want to look at whether there is anything that we're missing on our standard kind of topography scans. So we use that kind of added additional scanning technology quite a lot at OCL for the kind of milder cases. You don't need that for advanced cases because it's pretty obvious on a topography scan as to what's going on. But it's the ones that you might miss that you need these kind of extra devices and measurements for. So, having detected your patient as having keratoconus, what do you do with them? Until about 15 years ago, there really wasn't very much you could do with them. But then collagen cross-linking came along, and that's really transformed the future for these patients, because finally we have a technology that means that you can treat these patients and stop them from progressing. So, you can either treat them early because you know they're going to progress and get worse, or you can monitor them and look for progression or some early change and have a low threshold for performing cross-linking on them. So first trials on this were done in 1998. That's 23 years ago. And it's now widespread as the kind of gold standard technique for treating patients with keratoconus and stopping them getting worse. So the prerequisites for this are that the patient's cornea has to be at least 375 microns in thickness to allow safe cross-linking to happen. In the future, we may be able to cross-link thinner corneas, but thinner corneas generally mean that they've already got advanced ectasia and shape changes and their vision isn't that great. So ideally, we want to be detecting these patients early and then cross-linking them. So original treatments used to take about an hour per eye, and now it takes about 18 to 20 minutes because there's rapid high fluence cross-linking, which is done. And essentially cross-linking involves scraping off the epithelium or removing the epithelium in whatever way, and I'll go into that in a second. Soaking the cornea in vitamin B2, that acts as a photosensitizer, and then exposing the eye to UVA light at a certain wavelength. And that catalyzes a photochemical reaction that causes covalent bonds to occur between your collagen fibers. Okay, and the more bonds there are, the less easy it is for those fibers to slide apart and bulge any further. So in terms of how effective this is, now there was a recent study published looking at 5-year data from Moorfields, and the success rates were 98%. So that's pretty phenomenal as, in terms of efficacy for a treatment. And if you had keratoconus or a patient who had keratoconus, I really have a low threshold for cross-linking them. So as with any surgical procedure, there can be risks, and complications thankfully are rare, but occasionally because of the contact lens that they wear after the surgery for a week, you can get sterile corneal infiltrates. That happens in about 7% of patients, and they'll just resolve without any issue. Bacterial infections are uncommon, probably about 1 in 1,000, 1 in 2,000 cases. Very occasionally, a bit of haze occurs in the cornea, and this is quite normal to see some haze at 1 month after the surgery, but by 6 months, generally it should have disappeared. Rare cases have more prolonged haze, but generally rarely visually significant. Extremely rare reports of melting of the cornea in some cases, but that's usually associated with some sort of bacterial infection. So in general, it's a relatively safe procedure. It is pretty uncomfortable in the, not to go through, but in the healing phase, and first couple of days, your eyes really are very sensitive, but a week or so later, things are fairly comfortable and patients have got over it. The future there is to try and maintain the epithelium when you're doing the cross-linking. So far, there have been some trials where cross-linking is being done with an oxygen mask on, so that you get a high concentration of oxygen around the eye, and you can disrupt the epithelium by just sort of puncturing it rather than scraping it off completely. But the jury's still out as to whether that's as good as epithelium off cross-linking, and we've just got to wait and see what the sort of 5-year data shows on that. For the moment, the standard is to do epithelium off high fluence cross-linking, and we'll typically do one or both eyes of the same treatment session. So again, just looking at the Corvis, which was the dynamic assessment of strength of the cornea after cross-linking, and pre-op and post-op comparisons show that it behaves more like a normal cornea or a more rigid cornea after the cross-linking is done. So, cross-linking is fantastic, and that's now evolved into cross-linking plus other treatments, because there's the opportunity to try and improve the overall shape of the cornea when you do cross-linking. So different ways to achieve this, and I'm not going to go into all of them in great detail, but you can do topography guided differential energy cross-linking. I'll talk about that in a moment. You can do topography guided PRK. So you use a laser, take the patient's topography and guide the laser to reshape the cornea and then cross-link that eye. And that can be helpful for correcting shape and improving overall kind of curvature of the eye. More evolved is wavefront guided PRK, which I'll talk about very briefly. You can, in patients who achieve good spectacle corrected vision, who don't have very high prescriptions, actually do refractive trans PRK as you would to any other patient, and then cross-link them. And then there's things like Kera rings or Intacs, which are intracorneal ring segments, which you can add at the time of cross-linking. And that's really for more severe cases when there's a very abnormal shape to the cornea and you're trying to grossly improve that. So how you remove the epithelium matters, because if you just scrape it off with a mechanical kind of, scraper, you're not really changing the underlying stromal shape. And so most NHS units or hospitals will just scrape the epithelium off and then cross-link. My preference is to use PTK, which is a laser treatment, which basically removes a set amount of thickness from the surface. And when you do that, because you know that the epithelium over the cone is thinner than the epithelium in the area where the cone isn't, you end up flattening the cone. And very often you'll get an improvement in the overall shape of the eye. And studies have basically shown that you can get up to 1 or 2 lines of improvement in best correctors vision with their spectacles. So that's my kind of standard treatment, is to do an epithelial thickness map. I know where the thickest point of the epithelium is and the thinnest point is, and I'll set the laser to the thickest point of epithelium. And so it'll ablate through the thinnest point and shave off some of the cone so that it flattens that area. And then I'll do the cross-linking after that. So that's really in the kind of patients with mild to moderate disease. The other type of treatment that I do in sort of mild, moderate, perhaps not severe because it doesn't work as well, is a wavefront guided treatment. And this is to measure their optical wavefront, so the optics of light traveling through the eye. And you often see that they've got a high amount of coma aberration, and you can select that out in your laser treatment. So you're only treating certain aberrations in the cornea and then deliver the treatment to the surface of the eye. And very often the pattern looks a little bit like this. So you get some ablation occurring where the cone is. You don't get any ablation above or below that, and you then get a little bit of ablation in the periphery to cause a bit of compensatory steepening. The whole idea there is to try and make the cornea more spherical. So that's a more sophisticated kind of way of doing it than just PTK, because you're actually trying to specifically reshape the cornea. And then you just carry on with your cross-linking as you normally would. Now, just going back to that, in the studies that we have done at Moorfields and published there, there was up to 2 lines of improvement in vision in these patients, and general improvement in best spectacle corrected vision. So again, it doesn't get rid of their whole prescription, but it improves their best spectacle corrected visual acuity, which can mean that instead of needing hard contact lenses, they can wear soft lenses or glasses, which obviously has its benefits. So apart from laser reshaping, the other technology that's evolved from cross-linking is topography guided cross-linking. Now, to be able to do that, you need to be able to map the cornea out, but you also need to be able to follow the eye movement and to make sure that you're delivering the cross-linking treatment in certain areas in a different way. And the technology that we use in laser eye surgery, which is basically eye tracking and pupil tracking, has been superimposed onto these cross-linking machines. So the Mosaic cross-linking machine allows eye tracking and then topography guided differential energy delivery. So the way that works is that, say you have this patient and you know that they have ectasia in a certain part of the cornea, you can increase the amount of energy from the cross-linking that you're going to deliver to that area because you want to create more flattening. And then you can have a differential amount of energy in the periphery around that to create less of a flattening effect. So you'd pre-program the device. This is the actual programming interface. You can superimpose the topography map into it, and you can plan how much energy you're going to deliver in different areas, in different shapes. So in that patient, you would deliver more energy to the cone and then extend out in different zones back to a normal sort of concentric energy level. And with doing that, we generally do that in more advanced cases where you're really trying to flatten the cone. You can get up to 4 diopters of corneal flattening over a 12-month period. So, that's been quite promising in terms of treating some of the more advanced cases of keratoconus, where yes, we want to cross-link them, but we want to use cross-linking or some other adjuncting technology to try and improve overall shape. So, which of these technologies you use is really dependent on the severity of the keratoconus. A patient who has mild to moderate keratoconus doesn't need differential energy cross-linking. This is for the more severe cases. For the mild to moderate ones, I would use a laser to do some reshaping, either PTK or wavefront. And then the more advanced ones, I'd use a mosaic type treatment to try and get a better shape. So, that's the ability to change the shape of delivery also helps in cases, for instance, where you have pellucid degeneration. So keratoconus is really a central corneal ectasia. Pellucid degeneration is more peripheral. Now, in the past, your cross-linking delivery was just a circle in the middle, 9 millimeters. That would miss the peripheral part of your pellucid degeneration, and they'd continue to get worse. So, with mosaic, it allows you to actually deliver a concentric sort of crescent more peripherally and wider out near the limbus than you could before with standard cross-linking. So these sort of shape type cross-linking treatments allow you to treat patients who have not just keratoconus, but pellucid degeneration, or patients who've got radial keratotomies, who've got diurnal variation in their vision or shape change happening, where you may want to do a donut of treatment and not treat the center. So that's been quite interesting in how we can differentially deliver cross-linking to the cornea. So as I said, what I do is well, my real standard go-to is PTK plus cross-linking or wavefront guided trans-PRK plus cross-linking. I always do rapid cross-linking, so it generally takes me 25 minutes to treat both eyes, because you can do it simultaneously. And in worst cases, I would use either an intracorneal ring or mosaic type of cross-linking at the time of treatment. So, patients are obviously benefiting from being able to stop their keratoconus getting worse. But really what they're really interested in is, can they have better normal vision after the cross-linking? And, some of them get reasonable vision, but if their keratoconus is moderate or advanced, then they can get ghosting and glare and flare and all kinds of other issues. In terms of visual rehabilitation, and this is really where optometry comes in, the main go-to is glasses and contact lenses, and that's why your patients will come and see you. In patients who don't do well with those two modalities, then there are other options, and that's either the ring segments, limited types of laser refractive surgery, limited because you really don't want to make your patient's cornea thinner than it already is, and corneal transplants. So, in a lot of these kind of more advanced patients, RGP lenses or some variant of that is still king. And, I'm sure you know a lot more about lenses than I do, and the various types that are available. But it's always a balance between comfort and how much vision the patient gets. I'm just talking to you about some of the surgical options. And so, some of these patients who have been cross-linked perhaps have advanced keratoconus and are just intolerant of contact lenses, are sometimes a challenge, because they don't achieve good vision with glasses, and they come to corneal clinics wanting some sort of solution to their problem. So I use quite a lot of Kera rings. Intacs were a technology that were really developed for treating myopia before laser surgery. Laser surgery then came along and completely wiped out the need for Intacs, but then it evolved into being used in keratoconics. That's moved on to rings like Kera rings, which are specific to keratoconic eyes. And there are other rings like Ferrara rings and Meyer rings, which are rarely used these days. Kera rings are ring segments which allow you to grossly adjust the shape of the patient's cornea and try and make it more spherical. It can be very useful for reducing high amounts of astigmatism, and it can also improve aberration. So just to get your head around, how a Kera ring works, it would be great to have a tummy like this, but the keratoconic tummy on the left side of the screen is essentially a cone that sort of is hanging down. And what we're trying to achieve is a more rounded, kind of more prosperous looking tummy, if you like, and better kind of spherical shape of the cornea. So that can be achieved with these intracorneal ring segments. And they're implanted these days using a laser to make a channel in the cornea at a given depth, usually about 300 to 400 microns, and a little entry point, which you can see happening there. So that's a femtosecond laser, same sort of thing we'd use doing LASIK. That channel is created at a given depth based on the patient's corneal thickness, and then I can push in the ring based on the treatment nomogram. So these ring segments come in different sizes and different lengths, and so there will be different combinations of rings for different patients. Now, what's interesting there is that the reflex of that circle of light is rounded, okay, which basically means that the astigmatism that was there before, that's kind of like one Placido ring, has disappeared because of that ring segment being put in. So it can be quite effective, not in everyone, but the advantage is that it's reversible. If for some reason the patient vision gets worse, you can take the ring out. So I generally tell patients they've got about a 70% chance of improvement in vision. And you've got to remember, these patients are patients who can't wear contact lenses, and they've got advanced keratoconus and their vision isn't good in glasses. So 70% chance of visual improvement usually is appealing to them, and so is reversibility. So it's worth a try in that group of patients. So once that's done, you can combine that with other modalities. But often these patients either are coming to you with very abnormal shaped corneas and need crosslinking at the same time, or have already had crosslinking and can't wear contact lenses. So other ways of correcting vision in these patients, if they're intolerant of lenses, are either phakic intraocular lenses or some sort of surface laser. Now, phakic intraocular lenses are either ICL type lenses, which go in front of the natural lens, or iris clip type lenses, which are clipped onto the iris. They both work, they both come in toric formats, and they have their indications. The important thing there really is that it's important for the patient to understand that their vision is only going to be as good as what their spectacle corrected vision is. It's not going to be as good as an RGP is, or any sort of surface contact lens, because it's not going to mask the shape of the cornea. So this works well after, for instance, you've done a Kera ring where the shape's been improved, they've got better spectacle corrected vision, and they want to not wear glasses. But if they think that if they don't have good spectacle corrected vision, they're not going to get great vision with one of these implantable lenses. The other treatment modality in patients who've got stable keratoconus who've been cross-linked in some of these patients is to do a transepithelial PRK treatment, and that allows you to correct mild to moderate refractive errors. Essentially, you can only treat a sort of small amount of refractive error, and you really want to leave their corneas as thick as possible. But that's another option that works well as long as you know they're stable and not changing. So the thing that flashed up there about it only corrects regular astigmatism really relates to the phakic intraocular lenses, and that's why their vision isn't any better than their glasses corrected vision. So finally, just to touch on corneal transplants. So keratoconics who really have advanced disease do end up in our clinics needing corneal transplants. And these are usually patients who've either had a high drops or they've just got such abnormally shaped corneas that they don't even tolerate a spiral kind of lens and just don't see well, and they need visual rehabilitation. So the options for those patients are either a full thickness penetrating keratoplasty, and that's for patients who've had a high drops or some sort of scar in the cornea, which is going to make doing an anterior lamellar keratoplasty difficult. An anterior lamellar keratoplasty is where you're trying to leave Descemet's membrane behind and just replace the stroma in front of it and the epithelium there, which regrows. So how do we do that? We trephine down close to Descemet's membrane, and we try and get a cannula or needle as close to Descemet's as we dare without rupturing it, and we inject an air bubble there. That's called the big bubble technique. And if you're in the right plane, that bubble of air will find Descemet's membrane and it will detach it. And that separates it from the overlying stroma. Okay, so you can see it here. And there's a needle going into the cornea, pretty close to Descemet's, and the air bubble being injected. And you can see the air bubble now expand out. And it's spreading is that it's detaching Descemet's. Okay, so now there's a gap between Descemet's and the overlying stroma, and you can then go on to remove the overlying stroma very carefully, because you can easily rupture Descemet's membrane at this point, and then to suture on your donor cornea. So in case you're wondering what's going on here, Descemet's membrane is in this area here, and the reason there's no aqueous coming out of the eye is because the eye is still a closed system, because Descemet's is still intact. So the surgeon's removing the stroma, and the eye isn't collapsing because Descemet's is holding everything together. Okay, and then you'd put your donor cornea on there and suture that into place. Now, the advantage of going to those lengths to try and preserve Descemet's membrane is that it reduces your risk of corneal transplant rejection fairly significantly compared to a PK. But having said that, even a penetrating keratoplasty really has good survival. The best survival rates are in keratoconics, and rejection rates are about 1 to 2% per year. So outcomes are generally good, whatever the patient has. Now, keratoconic patients do get older, and they do need cataract surgery, and trying to calculate their lens powers is a bit complicated when their cornea is irregular and their K values are so high, and you sometimes got to fudge the optical power of the intraocular lens because you just know you're not going to be accurate. So we generally would aim more myopic than the printout says in the more advanced cases. But the other types of lens technologies that are helping some of these patients are pinhole type lenses. And you know that a lot of these patients' vision improves with the pinhole. So the IC8 lens on the left side of the screen is an actual intraocular lens with a pinhole embedded in it. So that's an optical lens with a pinhole in the center. And the extra focus lens is a piggyback lens. So that's placed on top of an existing monofocal intraocular lens. Now, the advantage of the extra focus is that if the patient doesn't like it or doesn't get an improvement in their vision with the pinhole, you can remove it and you still leave behind the monofocal lens. With the IC8, if they don't like it or have some sort of dysphotopsia from the pinhole, you've got to take the whole IC8 out and put a new lens in, which is slightly trickier. So it's not guaranteed that the patient is going to benefit from one of these pinholes. One of the ways I test them is that I put some pilocarpine in the eye to create a kind of tiny pupil and ask them whether they notice their vision's any better. And then if they do, I'd consider an extra focus implant. But it's variable. Some of them come back and say it makes no difference. So this was an interesting article, really, I came across when I was preparing this talk, and it was really someone asking what happens to all the keratoconic patients. I mean, we don't see that many patients coming in for cataract surgery. I mean, are they dying younger? We don't really know. It was a question that was asked in Cornea, which is one of the major journals, and And whether keratoconus really is indicative of some other kind of systemic disorder of connective tissue, which may predispose these patients to dying at a younger age. We don't know the answer to that, but it does seem like we don't see as many keratoconics having cataract surgery as we do in our clinic. So that seems odd when you come to think of it. So final things really with cataract surgery are, apart from the pinhole lenses, are really toric lenses, because a lot of these patients have high degrees of astigmatism. What we have at OCL is sort of this virtual guided toric alignment system, which allows more accurate placement of the ICL. So that green line that you can see is something I see in my eyepiece when I'm operating, and it shows me the axis of alignment for the lens. Now, again, it's similar to an ICL or a phakic intraocular lens. You can only correct the regular part of their astigmatism with the toric lens. So, that's as much as you can do. Some of them do well. If they've got a lot of irregularity, I would just put a monofocal in without any toricity, because it just complicates the correction of their vision with a subsequent contact lens if they need it. So to conclude, the future for keratoconics is really vastly different to what it was 20 years ago. And crosslinking has been a complete game changer. And it's now the norm for stopping progression of keratoconus. It's 98% effective. That's a very efficacious treatment, and complications are uncommon. Crosslinking plus in the technologies I've kind of talked about, laser surgery or differential energy crosslinking or intacts or Kera rings, all of those things allow us to now also try and improve shape and vision in these patients. Access to this stuff is still a bit of a postcode lottery in the NHS, and but it's becoming more widespread now. So going back to what we talked about, really, modern management, really important is detection and being suspicious of patients with who could potentially have it, and referring those patients in for a checkup. Visual rehabilitation is still mainly glasses and contact lenses. So again, optometry plays a key role in that. And then obviously hospital eye services are where cross-linking and other kind of surgical therapies come into this. So at Ophthalmic Consultants of London, I'm not the only corneal specialist. Ali Mirza works at the Western Eye Hospital. Alan Barsam is at Luton and Dunstable. And we all see patients for keratoconus and do all these treatments, really. So that's my update. And I'm happy to take any questions if you have any.
Thanks very much, Ram. We do have quite a few questions, so we're going to get going with them if you're ready. The first one was age in keratoconics. Do we often see young patients, for example, toddlers, age 4 or 5, young school kids?
Very unusual. I mean, it's really unusual to see kids that young with keratoconus, but you occasionally see the 11, 12-year-old who's got keratoconus. That's unusual, though. More likely you're going to see someone at 15, 16, and there onwards. But it's pretty unusual to get toddlers with the keratoconic cornea.
We have had lots of questions on the treatment of private versus NHS. So you talked a lot about what's available, the lasers and all the Kera rings and PTK. What can we do in the NHS, and what can, obviously, we can do all of that privately?
So, I mean, cross-linking is available in most NHS hospitals now, I think. Okay, I mean, Moorfields Cross, at least, which is where I work, we will do 60 to 70 to 80 cross-linkings a week. There are so many patients that it's now a nurse-led service. And it's just, at that kind of volume, it's really manual debridement of the epithelium and rapid fluence cross-linking. So rapid cross-linking, and the main purpose of that is to stabilize the cornea and stop progression. So that works brilliantly. I mean, all that data on the 98% 98% efficacy is coming from those clinics, so it works perfectly well. The other stuff is really, you know, the bells and whistles stuff, which is the trying to improve shape or trying to improve vision. That's only really available in centers that have a laser. So, you know, in an NHS setting, I think Moorfields in London is the only hospital that has an eczema laser, and those treatments aren't standard unless you have an interest in treating keratoconic patients. So, you know, I might treat a few patients that I see with those more kind of sophisticated treatments, but in general, they go to a common cross-linking list. Privately, again, they're available as long as your surgeon has access to a laser that can do that sort of thing, or cross-linking machines like Mosaic that allow that kind of differential application of cross-linking. So, you know, those more kind of advanced stuff aren't really widely available to everyone. But the standard cross-linking, which is 98% effective, and that's really important, is available to most patients.
How about the guidelines, Ron? So NHS versus private. If we have a patient with cross-linking, at what point can we refer into the NHS? Or at what point would you refer if we were able to?
Look, if you were suspicious your patient had keratoconus, you should just refer them. I mean, you shouldn't base your referral on whether you think they should be cross-linked. They should just be within the NHS system, because it's much easier to monitor for progression using tomography than it is to monitor for progression using refraction. So, you know, the threshold for cross-linking, you do need to show some progression on serial scans, and that's about 0.75 or 1 diopter of change. Okay, but you know, I wouldn't. If you thought your patient had cross-linking, had keratoconus, I would just refer them. I wouldn't refer them because you think that they need cross-linking. That just needs to be decided in a hospital setting.
Okay.
And so privately, the conversation really is, you know, either we can wait for progression, or, you know, you're 19, you've got keratoconus, we know it's going to progress, and it's more likely to progress than not, and cross-linking is a possibility, and, you know, which option does the patient want? Very often, the patient will choose to be cross-linked because they like, you know, it's stressful to have keratoconus. If you start reading some of these websites and keratoconus groups out there, patients get really stressed out, and they don't know how to put the information out there into context. They like to feel the security of being cross-linked and feel like they're not going to progress. Okay, and for a treatment that's 98% efficacious, it's kind of a no-brainer. I'd want to be cross-linked if I had keratoconus.
Well, I've got a couple of case scenarios for you, actually. We have a patient who's got stable KC with a graft in place, becoming a bit non-told to contact lenses. Is there anything that you could offer in the NHS or privately for these patients?
So the patient has a
stable KC, they've had a graft.
Okay.
But now non-told to contact lenses.
Not tolerant to contact lenses. Okay. So, you know, that's actually not an unusual scenario. And these days, what we would offer them is an ICL, so a toric ICL. You know, again, going back to what I was saying is, if they've got a reasonably regular corneal shape, then they'll get decent vision out of the eye with the ICL. If they don't have good shape in their graft, which can sometimes be the case, I would actually laser the graft first to try and regularize the shape, and then let it settle down for 3 to 6 months, and then look at their best specular corrective vision, and then an ICL. Now, ICLs in some NHS hospitals are funded and can be used at the discretion of the corneal specialist. So I don't know all NHS hospitals, but Moorfields has got funding for ICLs in some of these patients, and I put them into patients who are my NHS patients. You know, privately, obviously, it's an option that's more freely available.
Rom, can KC, once it's stable, start to progress again?
Yes, it can. So it depends on whether your patient rubs their eyes a lot. Okay, so, you know, even in keratoconics who've been cross-linked, you really got to reinforce that "don't rub your eyes" message, and, you know, show them the video in the MRI scanner, because cross-linking doesn't make your cornea like steel. It just makes it biologically stronger than it normally would be. If you keep rubbing your cornea repetitively every day for a few years, you'll begin to change its shape again. So, patients who are atopic, have allergies, who have a tendency to rub, it's important to be on top of that. They need antihistamine drops, they need steroid drops, they may need other kind of treatments to ensure that their eyes are comfortable and they're not going to be tempted to rub them. It's easy to say, look, don't go and rub your eyes, but it's not easy to do if your eyes are really itchy and uncomfortable. That's just your clinician saying don't rub them, but you've got to try and make that easier for the patient.
So we've had about 5 or 6 questions about the age limits of cross-linking. Is there an age limit?
There's no age limit, but the natural history of keratoconus is that it generally stabilizes by your mid to late 30s. Okay, so that's because you're naturally cross-linking your cornea. So most of your patients are going to be late teens, 20s, that kind of age group. It's unusual to need to cross-link older patients. The ones that I can count probably on one hand where I've had to cross-link 40-year-olds because they've already stabilized. So it's not that there's an age limit. It's just you don't generally tend to need to.
And is there a minimum age requirement?
So that we don't know. I mean, we've done there was a trial going on at Moorfields looking at pediatric population patients and cross-linking them. And I think they were cross-linking patients up to about the age of 11 or 12. What that showed was that the cross-linking in very young patients wasn't that stable. Now, we don't know whether that's because the cornea is still immature and biomechanically less stable, or whether these patients are more likely to be rubbing because they're young and they're not really listening to your advice. But there was more progression in the pediatric age group. So, very young patients, I don't think there's been any real big trials on that.
And following on from that, how many times can you cross-link the same patient?
It's often not necessary to cross-link more than once, but I've had to do it twice in some cases. Okay, so cases where I've had to do it twice are patients who've had cross-linking for pellucid degeneration in the past, and they've had a circular central treatment done, and they're still progressing peripherally. So now that we can cross-link in the periphery, you can go back and re-cross-link them. And the same in transplant patients, right? You can transplant them, and the graft is okay, but their own tissue is still ectatic, and it can still progress. And you can do a present of cross-linking outside the graft. So that's the kind of new stuff that you can do.
Just a couple of questions. We do have lots actually. Moving on to laser, what's the long-term stability of someone having laser remodeling with the cross-linking?
Seems to be quite stable in the studies at about 3 to 4 years. The thing to tell you about laser remodeling is that it's very thickness dependent. Okay, so you can't go crazy with it. It depends on how thick is the starting thickness, and you've got about 50 microns to play with. So you can only achieve what you can achieve with that much correction. So you're not going to try and attempt to make the cornea totally normal. It's often impossible to do that unless they've got very mild keratoconus. So if that's combined with cross-linking, it appears to be stable as long as you stick to safety thresholds.
Thanks, Rom. And the Kerr-ring, can patients wear soft contact lenses once they've had a Kerr-ring?
Yeah, I think they can. I've seen a few patients who've had contact lenses and they seem to work. I mean, some of them have sclerals rather than soft lenses. But very often the reason to do a Kerr-ring is because they're not tolerating their contact lenses. So, if they get really good vision with their glasses, then that's probably what they'd opt for, or an ICL.
Thanks, John. There are lots of questions, but I am going to leave it at this point. So if anyone does have any pressing questions, please do email me, probably at oclvision.com, and I will pass them on to Rom, who will kindly reply, and I will get back to you. Before we end, there is something that I would like to share with you, if that's okay. We're very excited to launch our new portal. So let's just start this. So this is our new referral portal. It is safe, secure, and GDPR compliant, and you can find it. There's a link here which I can send to anyone that wants it, or you can find it directly on our website. So if you go to our website, in the footer, there is a page, is a heading that will say refer your patient. So simply clicking that patient, I have already created an account. You create an account automatically when you refer a patient. You can just save your details. So I haven't done that already. My details are already logged in. And then you can either refer to a named consultant. So if you know who you'd like to refer to, for example, the fantastic Mr. Angunawela, you can just click here. Or if you'd like to refer to a service, you can refer to a service and either upload a referral. So if you've already written a letter, you can choose a file that's on your system. And for example, you could just upload patient X referral. Alternatively, if just for ease, you can just fill in a simple online form. I am going to have to fill this in, so we're going to call this patient X. So you just need their name, address, and their phone number, their date of birth, which I will put, and an email address. Simple as that. And then you can choose what you want. So our patient here has got a corneal disorder, so I click that. You can fill in as much or as little as you'd like to. So none of these boxes are compulsory. If you'd like to put in their correction, that's absolutely fantastic. If you have any information, you can provide it. If you want to put absolutely nothing, that's fine. You can just write here. We can put, for example, suspect Casey. And I've uploaded nothing else. At this point, you could attach a file. So I have a pentacam that I'd like to show Romesh here. So you can just upload your file. You click next, and all the referral details are here. My details, the consultant I want the next appointment, the referral form, anything I've filled in together with that. And then you hit submit, and then that referral will come straight to us. So it is a really easy and safe way for you guys to refer into us, and we hope you find it useful. If anyone does have any questions on that, please do let me know. And just quickly about the specialties we offer. So as you know, Rom's mentioned that we've got two other corneal surgeons here, Mr. Barsam and Mr. Mirza. We also run glaucoma clinics. We do a oculoplastic clinic with Susan, and we also have a retinal clinic with Mr. Wong, Lorenzo Motta, who do VR, and we also have Shah doing medical retina. Lots of specialties here. Oh, she says. And for those of you enjoying our WhatsApp groups, the consultants very kindly pop in case studies once a week. So if anybody would like to join our WhatsApp group, please feel free to tap this QR code or take a photo of it, and feel free to join it. Like I said, every week the consultants will post a case study. It's great for learning. I found it really useful. Other optometrists post their cases, a really great learning tool. And finally, our next webinar will be given by the very famous Shahram Kashani on the management of uveitis. His lectures were very popular last year when we ran our lockdown webinars. So I will send these out into the WhatsApp groups, and also an email will go out. So we look forward to seeing you there. And I am now going to run the poll. So if you could all please just fill in a quick poll for us. And Romesh, you can show your face again as we say goodbye once the poll is complete. We hope you've enjoyed this webinar, Rom. Thank you so much. It's been fantastic. I've learnt a lot, and I work with you every week. So, you know, you're still teaching me.
I like a surprise.
We are nearly there. So like I said, if anyone has any questions, please do just drop me an email or send me a WhatsApp, and I will get back to you. I look forward to seeing you next month for our next webinar, and we look forward to seeing you there. Thank you very much, Ron.
Thank you.
Take care, everyone. Have a great evening.